It's really an immense pleasure to not only be able to introduce Ken, but to introduce yet a real legend in the field, and somebody who, in reading his bio, has been a psychiatrist almost as long as I've been alive. It's an enormous pleasure to introduce Professor Sir Michael Rutter, who was the first UK Professor of Child Psychiatry at the Institute of Psychiatry from 1973 to 1998, and is now Professor of Developmental Psychopathology. He has an enormous range of achievements to his name and awards. I'm sure that they are all well known to you, so I will not repeat them all, except to say that he's had an incredible influence on a range of fields, including the field of personality disorders, and particularly, I think it's already been mentioned, but personally for me, his 1987 paper talking about interpersonality disorders really made an enormous impression, I think, on the field. He has contributed in so many ways. He's a Fellow of the Royal Society, a founding Fellow of Academia Europaea and the Academy of Medical Sciences, and he has published around 500 scientific papers and over 50 books. It's my pleasure to introduce Professor Sir Michael Rutter to speak on the topic, do personality disorders constitute a meaningful diagnostic grouping?
Well, thank you very much for that very generous introduction. It's a great pleasure to be here, so many thanks to the organisers for inviting me along. The first slide, where's this thing? Oh, there, right. As you will see, I've been involved with the WHO and the APA for a very long time, but I no longer am involved with either. And what I'm presenting is very much a personal view and not a view from either the APA or the WHO. Now, the situation in ICD-10 and DSM-4, which are the last editions of both, is a strange one. Personality disorders were treated as conditions to be considered only in adult and not in childhood. Personality disorders were placed on a separate axis from the main block of mental disorders. The proposals for ICD-11 and the actuality of DSM-5 abolished this split and imply that all personality disorders can be considered in childhood as well as in adult life. In short, a developmental perspective is assumed, rightly in my view. So what were the problems that the new versions of both classifications had to meet? The first is the huge overlap among different personality disorder diagnoses. All studies have shown that. At present, the DSM and ICD approaches appear both divergent and irreconcilable. That is a problem because to have two competing classifications really makes very little sense when the whole purpose of classification is communication. But if communication involves one person speaking one language, another a different language, it won't work. Both classifications appear to want to view all PD diagnoses as comparable in the concepts involved, whereas it's obvious that that can't possibly be the case. Both classifications conceptualize PDs as beginning only in adolescence or early adult life, but the descriptions of individual PDs note that there is often an onset in infancy or early childhood. This is the case with avoidant or anxious PD, for example. So, what are the similarities and differences among the concepts of temperament, personality, and personality disorder? Well, I don't know that there's total unanimity on that, but I think the view that I presented in my 1987 paper would meet with most people's agreement. So that temperament is concerned with simple, non-motivational, non-cognitive, stylistic features of which emotionality, activity, and sociability are best validated. Neurobiological correlates are evident, but this does not differentiate them from other behaviors, although some of the initial writings suggested it would. Personality, by contrast, if you like, is concerned with what you do with the temperament that you have. It refers to a coherence of functioning that derives from how people react to their attributes, how they think about themselves, and how they put them together in some form of conceptual whole. Some personality features may be dealt with in terms of dimensions, such as obsessionality, but most are best seen in terms of cognitive, emotional, and social mechanisms. Personality disorder is different yet again in that, as traditionally conceived, they are viewed as variants. Some of them are viewed as variants of affective disorder, autism, or schizophrenia, but others are best characterized by a persistent abnormality in social relationships and social functioning. Now, let me turn to say a few words about some of the key personality disorders to illustrate the points I'm trying to make. Now, unlike most other PDs, this is specified in DSM-5 as often starting in infancy or childhood with shyness, isolation, and a fear of strangers and new situations. And it is noted correctly that there is huge overlap with social phobia generalized type, and it's unclear why it should be classified as a personality disorder rather than a chronic mental disorder. That is particularly the case given that fluctuations over the age span are common. Now, of course, they do occur in all sorts of personality disorders, but they're particularly common here. There is some good evidence that this personality disorder and social phobia share the same genetic liability, the difference between them being attributable to specific environmental risk factors. Schizotypal disorder is different. In ICD-10, this was grouped with schizophrenic disorders rather than PDs, but in DSM-5, it is grouped with cluster A personality disorders on the grounds that the individuals often appear odd or eccentric. The genetic findings show a substantial shared genetic liability with schizophrenia, and follow-up data on a familial high-risk group by Eve Johnson and her colleagues in Edinburgh showed that some individuals with a schizotypal disorder went on to show schizophrenia. So the evidence clearly indicates that this is an important disorder, but it is one more appropriately viewed as a mental disorder that is a variant of schizophrenia rather than a personality disorder that should be in an entirely separate grouping. Antisocial personality disorder, or dissocial to use the ICD terminology, is regarded in DSM-5 as a cluster B personality disorder, a grouping for disorders that appear dramatic, emotional, or erratic. ICD-10 did not use the PD clusters, but in all other respects, it did treat the condition similarly. And it was specified that the diagnosis could only be used in individuals aged at least 18 years. The symptoms for antisocial personality disorder included features of psychopathy, an inclusion that meant psychopathy could not be diagnosed in the absence of antisocial behavior, despite the fact that recent research indicates that psychopathy often occurs without antisocial behavior, and it may be evident in early childhood. Accordingly, in the proposals for ICD-11, the proposal is to combine what used to be conduct disorder in childhood with antisocial personality disorder in adult life, bringing the two together. The evidence in support of that is that from Lee Robbins' 1966 and 1978 papers onwards, almost all antisocial personality disorder is preceded by conduct disorder in childhood, although only a half or less of children with CD go on to have an antisocial personality disorder. And that surely requires that the two be combined. But for the diagnosis to be meaningful, it needs to be stripped of its psychopathic features. It was the lack of a developmental perspective that led to this absurd separation of CD and antisocial PD, and it's good that that may now be corrected. Psychopathy was not included at all in either ICD-10 or DSM-4. The proposals for ICD-11 specify the need to have a category for psychopathy and that this should be able to be used with children as well as with adults. It is noted there as needing further testing, and that's because most of the research evidence is based on questionnaire scores rather than clinical assessment, and because of queries over informant differences between self-reports and the reports of others. Psychopathy, surprisingly, is not even listed in the index of DSM-5, let alone as a category, although limited prosocial emotions, whatever that may mean, is included as a specifier for conduct disorders. Now, the proposals for ICD-11 may or may not happen in the way that the expert committees recommend, because one of the things about the way these organizations work is that it is actually decided by bureaucrats at the end of the day, and we have our say, but whether anybody will pay the slightest bit of attention to them remains to be seen. Now, what about the other PD categories? Well, there are the theoretically derived concepts, such as borderline personality disorder, about which much of this meeting is concerned. And in ICD-10, this was included only as one variant of emotionally unstable PD. Well, there is no doubt that the behavioral pattern exists and that it is important. And I won't go through the evidence on that because you're all well familiar with it. But the theoretical assumptions lack adequate empirical support, and there is apparent overlap with so-called histrionic PD. And then there are extreme traits. Obsessive-compulsive PD and avoidant PD appear to represent extreme trait manifestations. So that from someone who's not a card-carrying personality disorder researcher, the field looks in need of a rethink. So we have to start, though, I think, by saying, do personality disorders matter? Well, definitely is the answer, yes, because individuals with personality disorders show substantial impairment and suffering. PDs show considerable persistence over time, but longitudinal studies show considerable changes over time and a proportion of very substantial remissions, as we've heard in some of the papers at this meeting. The presence of a PD is associated with a less good response to treatment of accompanying mental disorders, and PDs are fairly common in the general population and are much more common in clinical samples. So we have to have a way of dealing with PDs. DSM-5, at least to me, was a disappointment because what they put forward are two utterly different approaches without saying how they may be resolved. And personality disorders are much too important to be just left on the side, as it were, to be argued over, as if this was simply an academic matter. It's not an academic matter, or at least it's not only an academic matter, because it matters clinically, and we need to get that right. So the key question then is, are they best dealt with by a separate classificatory grouping? Now, doubtless the audience is going to be mainly against me on this, but I don't think they are. I think the classification is currently unsatisfactory, and it is in need of a radical rethink. And this is illustrated by the fact that a very distinguished group of people on the Working Party for DSM-5 couldn't come up with something that got general acceptance. Secondly, the research needs are similar to those for all mental disorders. And so the style of research needed is not that different across mental disorders and personality disorders. And the treatment needs are also similar. The issue of whether pharmacotherapy plays a significant role in the treatment of PDs is perhaps a bit different, but in essence, there is the usual problem of marked individual differences in people's response and the need to take a psychological approach as well as whatever else you do. A developmental perspective, which I have kept coming back to, emphasizes also the similarities between personality disorders and the rest of mental disorders. The current difficulties in diagnosis and classification could result in PDs being pushed to one side. I hope that won't happen. They're much too important for that to be satisfactory. But we are all going to have to get our house in order, I think, if that's not going to happen. Because there's a danger of having a classification system that does not have a separate axis throughout, and that is true of both DSM-5 as it is and ICD-11 as proposed. There will be no separate axes. We need to consider how we deal with all of this. And at that point, I rest my case, and I think there's plenty of time left for questioning.
Well, thank you very much for a wonderful presentation, and I think that will provoke many questions, and we open up the floor. Please use the microphones, and please identify yourselves when you ask the question.
Joel Paris from Canada. You said the theoretical assumptions behind the construct of borderline personality disorder aren't worked out. What do you mean by that? Are there any theoretical assumptions?
I think it's used rather differently in North America than it is in Europe. Insofar as it is used, and it's a diagnosis much less used in Europe than in North America, it is seen as a description of people who have an important mix of characteristics. Initially, the view of borderline personality derived from a psychoanalytic orientation in which there was a clear empirical, clear theoretical reason for it, and it's that which I'm saying. I'm not convinced that the empirical evidence supporting that is valid. But I come back to the fact that the patients who have that label for their problems, they exist, and it's a group that is very important that we know how to deal with.
Do you want to go up to the microphone, Peter? Oh, Antonia first.
You want to go? Okay. So I'm very sympathetic to the way you've constructed things, and I agree with many of the problems in DSM-5, but it does strike me that even if you don't consider borderline personality disorder in the context of the theoretical framework that it was first described, it is fundamentally a disorder about interpersonal functioning.
Yes.
And there are not a lot of disorders that we know of in our panoply of disorders in psychiatry that have that as their core feature. It's true that autism does, for example. And when I have thought about this myself, I've wondered whether we ought to clump those together into disorders of social functioning, where fundamentally we lack neuroscience because social neuroscience is an infant field. But I wonder whether there, it does seem to be in that sense an orphan disorder. I can very much sympathize with the idea that avoidant is really somehow very tightly related to some anxiety disorders, and schizotypy and avoidant very tightly related to the psychotic disorders. But I think maybe we all talk about borderline personality disorder more at a meeting like this because it does feel fundamentally different. The patients are there, they are very real, they suffer in a very real way, but the problem lies in the very complex nature of the way they interact with others. And there's no really good way or category to classify that disorder. So I wonder what your thoughts are and whether you think there are other disorders that lie in the domain of interpersonal dysfunction.
Well, the first answer is your own, autism, clearly, and one might well put schizophrenia similarly, although
there's other stuff there too.
There's other stuff there too, right.
Yeah.
One of the issues that strikes me as a developmental researcher is that our conceptualization of the various ways in which social functioning gets impaired is woefully inadequate.
Yes.
And so that, for example, the concept of a broader autism phenotype is one that's widely supported by empirical findings that it exists, but it is not supported by good measurement. And so that the issue for those of us who are concerned with autism is how do you differentiate between those social abnormalities that are part of autism and those that are part of schizophrenia, anxiety disorders, personality disorders. And we don't have good answers to that.
We don't have even a good language for
it,
I
don't.
think. Yeah, no.
So I'm all with you in terms of the need to conceptualize this in terms of social functioning and then deciding what we do with it. But the parallel with autism is surprisingly close.
Yeah. Thank you.
It's difficult to disagree with much of what you're saying, but I think the real question is whether or not we're tilting at windmills in some ways, because, for example, or which way round we ought to do things. For example, I've regarded social phobia as a completely useless diagnosis. I have done for the last 40 years, having done research first on it in 1969, because I think it's actually linked to the avoidant personality disorder is actually what the diagnosis is, and the social phobia, if it's generalized, is really part of that. So I think by picking out the individual disorders and saying, well, it should be better conceived as a mental disorder, I think you could equally argue the other case. The thing which I do feel quite strongly about, though, when you're saying it's the same playing field, we've got the same research needs, the same clinical needs. One of the big things about personality disorder which differentiates it, if we do take a long-term perspective. Now, we do for many other disorders as well, and we mentioned autism and so on, but I think the advantage of that, in so many of the disorders we come across in clinical psychiatry, and Glenn Gabbar was talking about yesterday, we do things in 10 minutes and we treat symptoms. Personality is important, it's got to be made more important, and we've got to have this longer time scale and look at things in a different way. And I think the question of improving relationships versus relief of symptoms, I think there's an awful lot of differences there. I mean, obviously there's overlap as well, but I think that emphasis on differences and, of course, having this longer view makes the case for personality disorder being continued. And I personally feel very strongly, one of the big things I've always supported about DSM, that actually a separate axis for personality disorder is essential. And eventually that will come to pass, because I'm a dogmatic psychiatrist and everything I suggest eventually happens. So, but I think for that reason, I think although it looks very sound, I think it's probably unwise.
Well, I knew that there would be attack from the floor from one particular source. Let me treat seriously the sort of objections you put forward. One of the notions in terms of personality disorder, as it used to be seen, was that this was a lifelong condition. But the prospective studies about which we heard in the symposium this morning, make it clear that's not the case. That's to say, yes, they are quite persistent, but they also remit. Now, one may say, does remission mean removal of all aspects? Well, probably not, but it certainly is associated with the removal of impaired social functioning. So, I don't have a strong view. In fact, I don't really have any view as to what is the proper solution for this. But it does worry me that ICD and DSM are going in such different directions on that. I don't take the side of either at the moment, but classification is a tool for communication. And if we aren't talking the same language, then we will have difficulty. And does that matter? Well, yes, it does. I worry less about it from a scientific point of view than I do from a clinical point of view, because we need, in the UK, to be able to make use of the studies done using a different approach under DSM and vice versa. So clinically, I think to have these different ways of doing things is problematic. And whether it'd be better to have a separate cluster, I think on the whole I'm not in favour of that. But what I am concerned about, as I ended up in one of my last slides, is a danger that because there is disagreement on how to deal with it all, personality disorders will be pushed on one side and not given the proper attention they deserve and badly need.
Harold?
I'd like to engage you a little bit more on the question of axes. Another aspect of personality and personality disorders is their tremendous impact on health in general and on other psychiatric disorders. So that it seems to me that having a separate axis allows clinicians to really focus on looking at the impact of personality, and especially personality disorders, on other psychiatric conditions, medical conditions. So I'd be interested in your thoughts about that.
Well, but I think that applies across the whole of psychiatry. DSM-3 made a big mark on having clear categories with no overlap between them. And the evidence now is it doesn't work. So that, for example, you couldn't diagnose in DSM-4 autism and ADHD. Now you can, because numerous studies, both sides of the Atlantic, have shown the high proportion of cases who meet both. So the notion of discrete categories, I think, doesn't hold up. And that raises the question as to when there is multiple diagnoses occurring together, what are the mechanisms involved? And calling it comorbidity doesn't solve the problem at all, and it provides a way of identifying a clinical issue that needs to be studied in terms of the mechanisms. Now, they may have overlap because of shared risk features. but they may also have because one disorder creates an increased risk for another, and we need to study that. Whether different axes would help or hinder that, my own feeling, but reflects my own stance, I guess, is that axes would actually make that more difficult. But I am sensitive to the danger of the present situation that we have. Now, multi-axial approaches was something I was involved with lots of other people in pioneering. So I'm in favor of multiple axes in general, but I don't think in this particular case they have served the needs well. But time may prove me wrong. We will see.
Yes, could you come up to the microphone, please?
Hello. I'm not from the front row. My name's Tom Pennybacker, and I just wondered if what you're pointing out, if we step back from it, is that we don't have something that I think of as a mature epistemology of mental disorder. It was kind of caught a bit in Peter Tyra's comment about,
yes,
well, is it social phobia or is it
yes,
PD? That actually, it's very hard to know what we're really trying to describe. And I think it came out in Glenn Gabbard's talk yesterday. I think he listed about 7 different ways that you might think about mental disorder, and which we kind of often condense down into biopsychosocial, but we don't have a really coherent way yet to put together a classification.
No, I agree with that. Now, there was a time when some very distinguished people hoped that neurobiology would solve the problems, but it's become clear that it doesn't. And if one approaches it from a genetic perspective, which is one of the areas I work in, it obviously couldn't do. Genes do not code for diagnoses. Genes have effects on proteins, which in turn is related to the liability for disorders, but the route from the one to the other, we understand surprisingly little about. And it won't land up, I think, with helping in the way we conceptualize disorders. Do we need to do that? Yes, I agree with you, we do.
I apologize. I am from the front row, at least today. And I'm sure you've heard enough from me. But it would seem to me that if there's a disagreement between DSM-5 and DSM-5 Section 2 and 3, and there's a disagreement between ICD-11, that may be an opportunity and not a tragedy. You began in the earlier part of your talk to say that the final decisions are made by committee, in the back rooms sometimes, with lobbying efforts. And it seems to me if we decide that we want ICD and DSM-5 to be similar, then that decision is going to be made in the back room by a committee. So we might have an opportunity to begin to do research about both diagnostic systems against each other or in parallel to see which one has more clinical utility, perhaps predicts less comorbidity, and might lead us to some kind of what I want to say, and I'll pick up on your biological statement, clinical truth, because that's what we're really after here. Sure. So I'm not sure that that would be terrible if we, in meetings like this, would not decide that my way or my country's way is right, but we now have an opportunity to compare two systems that presumably wise people arrived at through some kind of concerted and thoughtful effort, and to see which one's more practical for the field.
Okay, well, that's a very good point. I agree with that. I'd feel more comfortable about it if I thought there was a hope in hell that that would actually happen. But, I mean, one of the problems is funding. Now, I don't quite understand the point that Tom Insel is making in talking about what the National Institute will fund. But in the past, you really had to follow DSM. And for the most part, because DSM and ICD in the last iteration were reasonably close together on the big issues, quite major differences on small issues, but they don't matter so much. But whether that would be true now, I don't know. But you're right. The diagnostic system is not a codification of absolute truth. I mean, it's a set of hypotheses, if you like, given our best guess on how to make sense of the disorders that we see in the patients that we treat. And therefore, one should be very sympathetic to putting it to the test. Let's find out. And if that were done, that would definitely be a good thing.
I think there's one other factor that we haven't brought into this whole picture. If you think about autism, about 20 years ago, nobody knew what autism was. We were still calling them icebox mothers, and autism was just something that was kind of in the closet. And then the families got together and started advocacy.
Yes.
And the advocacy on autism is enormous, and they've gotten to people in Congress, in the Senate, in the United States, and then the money came. And I've watched this whole development of borderline personality disorder and personality disorders for the time period you've discussed. And the research has moved, and the treatment has moved, but the advocacy is in the lower levels. And until that comes, then you'll see the money, and then the back room will make better decisions. But it is, I agree completely with Ken that it happens in the back room, but it's the money and the families and the people coming out that are going to make the difference with this disorder. And then all of these things will get settled very quickly when there's research money and treatment money. So come on, folks, you have to get going here.
No, well, you're right. The groups of parents in relation to autism certainly have made a big difference in getting funds and getting things happening, and they have worked with professionals. So it's not as if it's them and us, it's us together. But one of the key things is people standing up as a senator or whatever it may be, saying, I have. And on the whole, borderline personality disorder is not something people are going to be too happy about saying. Should they be happy? Well, if it's a disorder like any other disorder, why not? But this definitely makes a difference if people can stand up and be counted. And the United States has powerful lobbies. That's a good thing and it's a bad thing. The good thing is that it brings funds when it can be harnessed in the right way. The bad thing is if it's done in a way which isn't really in keeping with the needs, then it's not such a good thing.
Well, I might go to the very, very front row, in fact, and ask a question if that's okay. You've talked a lot about interpersonal dysfunction, but yes, you haven't talked about intrapersonal dysfunction. And where is the self in all of this?
Oh, okay. Well, that's a good question. No, I didn't deal with that, but that's not because I don't think it's important. To the contrary, I think it is particularly important in relation to personality disorders. Do we have good ways of measuring that? I'm not so sure. But the self is a key, and we must find ways of dealing with it satisfactorily. I don't see that as in opposition to the interpersonal, but I do see it as complementary to it and equally important. The opposition has simmered down now.
Yes. Well, if there are no further questions, I might... Eric...
Oh, thank you very much. Thank you.